Yeah, thank you. Thank you everyone for being here and also my excellent panelists for joining this session. So we know that cervical cancer is quite unique. It's a non-communicable disease, but it's caused by infections. And if we diagnose it early, it's not a death sentence, but it's very treatable. While all the weapons for us to preventing and treat HPV infections and the cervical cancers are available and are highly effective, cervical cancer remains the fourth most common cancer in women globally, claiming 350,000 women's life every year. And notably, over 90% of cervical cancer deaths actually occurred in low and middle income countries, reflecting critical inequitable access to the health services. WHO issued a global call to action towards cervical cancer elimination in 2018. And since then, the funding and the political commitment towards cervical cancer elimination have increased substantially to advance the 17 and 19 targets. In this section, we will explore how innovations can contribute to the elimination of cervical cancer. And we will first hear innovative HPV and cervical cancer programs from Dr. Adeola and also Dr. Huchko. And then our panelists will share their insights on what kind of health system changes are needed to empower innovation. We will also open the floor for questions and interactions at the end. So over to you, Dr. Adeola.
Yeah, thank you for having me. I would say that Equitable Health Access Initiative, we're focused on the secondary prevention of HPV. We're doing a little bit of work on primary prevention we created an electronic immunization record system with an automated reminder for women, for girls, and also children under 5 on routine immunization. We're hoping that this is going to support the ongoing effort of the Nigerian government to ensure that girls between the age of 9 and 14 years old get vaccinated for HPV. And so, I mean, after this mop-up exercise of making sure all the girls are vaccinated, the question is what happens to the girls that are 6 years old or 7 years old, and how do they get reminded in 2-3 years' time that they are going to get vaccinated? So we're hoping that the electronic immunization system with automated SMS reminders and tracking would be able to ensure that those girls that grow up to be 9 years also get HPV vaccination. But we are focusing on secondary prevention as well, looking at conducting a study. This would start in the first quarter of next year on how medical grade tampon can be used for self-sampling and testing in Nigeria. What we are looking at is we are looking at the acceptability and effectiveness of self-sampling for HPV screening in the context of low middle income countries like Nigeria. We're also going to be looking at cultural factors and social acceptance, as well as the feasibility of actually having self-testing at home in perhaps rural, urban settings and underserved population. Another key component of the study that will be conducting is actually the cost effectiveness analysis. And we're going to be doing some microcosting, looking at direct and indirect costs that are involved, comparing the cost of self-sampling as against sampling by healthcare workers using cervical swabs. Also, part of the study will be looking at community mobilization, looking at what strategies are actually effective at the community level for increasing demand and uptake of cervical screening amongst women and in Nigeria. Yeah. Thank you.
Thank you. Thank you so much. I mean, what inspired me the most from your team's work is like you are not only apply the technology, but actually more like service delivery model or the strategy to reach to the target population. So thank you for that. Our next speaker is Dr. Megan Huchko. She will also share her innovative program in Kenya and Uganda. Over to Megan.
Hi, good morning, everyone. It's not letting me turn my video on, but I will just talk. I was excited when Hui invited me to join this panel. She started working with our group in Kenya and Uganda, where we're working to deliver both primary and secondary screening in rural areas of both of those countries using a package of innovations that we've looked at in separate studies in the past. So we are working through a NIH-funded consortium to provide primary screening, primary prevention through vaccination of 9 through 14-year-old girls in periodic community health campaigns together with HPV-based screening. So you can go to the next slide. These are the areas that we're working in Hoima district of Uganda and in Kisumu and Siaya County of Western Kenya. And these are just some examples of central scenes from those areas. You can go to the next slide. So our model of care actually developed out of a model that was used to meet the 90-90-90 goals for HIV prevention, care and prevention, in which communities were mobilized to get screened or tested for HIV and then immediately connected for treatment. So we started looking at this model about 8 years ago as HPV testing was being more widely introduced. We could bring women into central areas in their village with tents that were specially designed that had private areas that allowed for self-collection. We could do mass mobilization and education and then use some of the efficiencies of scale to screen women. And we found that to be effective and cost effective. So through this grant, we decided to see how we could also mobilize girls for either primary or mop-up vaccination. And we've been working directly with the government and working with community health volunteers to bring the girls in. And then in some sites, we were coupling directly with schools. So you can see this big group of girls is coming in through their school, for vaccines as a way of getting tracked. Sorry, I'm getting a message. Then you can go to the next slide. So we, as Dr. Adeola mentioned, are using self-collected HPV. We have in prior studies shown that it's acceptable. So that's one of the innovations. And then we're using mHealth. We have developed an app and are testing this in a large study to see to aid community health promoters in their counseling and to do case management, provide visuals for women to understand the screening and treatment process better, and then provide the results by text. So the app can be used either on the phone or on tablet as it's used here. You can go to the next slide. The last two pieces of innovation are our mobile treatment units, where we bring treatment to the field. We pack up a team and supplies in vans and either set up tents or go into more rural health facilities that don't have the capacity for treatment, and over a period of a few days, offer treatment with cryotherapy. And I think one important innovation is that our team has a portable LEAP unit. So we're able to treat women with more invasive or larger lesions. And then just the last slide to wrap up my brief intro is that we have packaged both health systems and technological innovations to reach a large proportion of the population with vaccination screening and treatment follow-up. And our preliminary results have shown that we've been able to reach a much larger portion of the population than clinic or school-based service delivery alone. And when we joined our team to do some costing and cost effectiveness analysis, so that's a really important component of utilizing and thinking about scaling that. And so we are pleased with the primary results and are looking forward to seeing the more final results.
Thank you. Thank you, Megan, for sharing this great program. Myself and also one of our students here, Kiara, we have the pleasure to visit the site and observe this amazing program in the summer. I mean, this is like the integrated service that provide both the preventive and also early screening, and then followed by the treatment for adolescent girls and also women. And I have seen great collaborations with the Ministry of Education to make it possible to advocate for this opportunity in the school. And also using our community health worker, they just form a trusted environment and encourage lots of women to come to the fair and receive the service. So that's really excellent. Thank you. So now I have a question to our guest here, Dr. Gupta. Can you tell us more about Sabin Vaccine Institute's work on cervical cancer, especially the Global HPV Consortium launched last year? And how are you approaching this work with a lens on disease elimination?
Good morning, Wenhui, an excellent question. So Sabin Vaccine Institute actually got into cervical cancer elimination space last year. You know, we just completed 1 year. And the key motivation really was that while we had this a very beautiful aspirational strategy from WHO, you know, with the goal to eliminate cervical cancer by 2030, we were seeing slow momentum, but also a lot of siloed and fragmented efforts. And there was an erroneous impression that was being built that just getting HPV vaccine introduced and vaccinating just adolescent girls between 9 to 14 years is really going to do the trick. And as you know, that is not correct, because while vaccination is a very important, essential first step, it is by no means sufficient to stop a cervical cancer. And that's what really set us thinking. And we then envisioned a global HPV prevention consortium, very focused on cervical cancer elimination, where we actually brought forward 4 key guiding principles. The first was integration, where we started to say, look, primary and secondary prevention must come together. So we need to vaccinate these adolescent girls for sure, but we also need to lay equal emphasis on screening. And the third very important dimension that was absolutely falling through the cracks was treatment of precancerous lesions. So we know cervical cancer progresses slowly in women. It gives us a window of opportunity. You know, it normally takes 10 to 15 years. So that is the time when women can be screened and the precancerous lesion can be very easily removed, you know, through ablation. So I'm sure some of you already are aware, you know, when we started to look at the data, of course, on vaccination, you have good data, right? But on screening, the data is very patchy and uneven. You know, so we are now saying, okay, you know, 4 in 10 women in LMICs, where 95% of cervical cancer deaths happen, actually at some point of time probably underwent some sort of screening, but it's not reliable data. But if you want to really look up data on treatment of precancerous lesions, it doesn't exist at all. So integration was the first principle, but also important to understand that if we are serious about integration, we need a genuinely transdisciplinary approach. And that is why this consortium is unique in the sense that it pulls together diverse actors and institutions together that are working not just in vaccination space, but screening, cancer control, reproductive health, HIV, women empowerment, youth empowerment, et cetera, et cetera. So a lot of people who need to come together, but have historically functioned and operated in silos. The second motivation for us was the whole sort of issue of cervical cancer being a disease of inequity. So as you said, 95% of deaths happen in LMICs. But more importantly, when you start to dig deeper, you see that in Africa, the incidence is so high. And for example, Africa has 4 times higher incidence of cervical cancer compared to North America, but 8 times higher deaths. And as we started to dig even deeper, we sort of started to surface the nexus between HIV and HPV, and the fact that women living with HIV have a 6 times higher risk of developing cervical cancer. It develops much faster in those women, but also in their case, it's almost a death sentence. So women may not die of HIV anymore, but there is a high risk of them dying of cervical cancer. And the final thing is really sustainability, because as has been highlighted, there is work going on in countries, right, on a small scale, but unless we mobilize political will and sustainable financing, these efforts, will not bear fruit. So that's another important principle for us, and heterogeneity, because every continent is different, every country is different, and within country, we are seeing a lot of subnational differences.
Thank you so much. You actually pointed us several very important concepts, like the disparities of disease burden, the importance of integration of the services, and the lack of reliable data for some of the services. So that's really great. Let me move to our other guest online, Dr. Mali. You lead the national program or institution like addressing cervical cancer in Kenya. So how are your organization approach the potential for cervical cancer elimination, and what are the challenges in your country?
Well, thank you very much for having me this morning in Duke. I am privileged to speak before this great meeting. I want to acknowledge and agree with all the remarks, comments that my fellow panelists have presented. Well, I head the National Cancer Institute of Kenya, and we are aligned to global policies and initiatives towards elimination of cervical cancer. I like always to paint the burden that exists, just like has been mentioned by my colleagues, that we are dealing with a disease which is posing a big challenge from a public health perspective in our country, just like it is in other LMICs. And it's a disease that is purely preventable, and a disease that is curable when diagnosed early. And if unfortunately diagnosed a little bit at an advanced, stage 2, stage 3, holding all the factors constant, there is still a chance for these patients to be treated. But our initiatives are all aligned to the WHO call to elimination of cervical cancer by 2030, as we are all aware. From a government perspective, I really want to acknowledge the work which Dr. Megan and the team have been doing in Kisumu and Siaya counties, which are in a very high HIV prevalent area, underscoring the nexus between HPV and HIV. And that is also the region where most patients are diagnosed with cervical cancer. We are committed to both primary and secondary prevention, since these are the initiatives. I am speaking here in the middle of an implementation science program, and I am happy to comment on the innovations as a way of implementation science towards preventing cervical cancer and diagnosing early through screening. It is quite remarkable. And we have talked about, the science is available, the strategies are well known, but then how do we move them now, to real practice and expect outcomes that are desirable? So from our Kenyan perspective and from a policy, perspective, we are glad that these pilot projects that have been tried out have been very successful, and quite excited that, we should now scale them up and adopt them as policies. Self-sampling, for instance, is addressing a cultural barrier where women feel uncomfortable to go to the clinics, and the procedure is very uncomfortable. So having an intervention of self-sampling is definitely going to break the barriers, which are cultural and also physical at the same time. This is definitely going to increase, the uptake for screening. I know we are all working towards, 70% of our women between 35 and 45 being screened. And we are working towards that through several campaigns, either through social media and conducting regional screening efforts. In this coming week, we have lined up several screening programs across the country. As a way of sensitization, October is known to be a cancer sensitization month. We are looking at also how then do we improve HPV vaccination amongst our girls and hopefully extend to boys soon. And our uptake has been improving. We launched this vaccination in 2019 in Kenya, and the data that we have right now shows there is acceptability as we move on, and our intervention is using, Ministry of Education structures and continuing to educate our parents. At the same time, we are also using the community health promoters in the community. We have rolled out countrywide education package for our community health promoters. And one of the indicators is sensitization on HPV vaccination amongst our girls who are eligible. At the same time, educating our, both men and women on importance of cervical cancer screening, as much as it's not directly a man's disease, but it is a concern of a family due to the challenges that it poses when one family member is diagnosed. So I'm happy to report here with confidence that we as a country adopting these strategies and using innovation as, an implementation strategy is really great, because then we are now working towards improving on uptake for both primary and secondary prevention for our patients. I'm a clinical oncologist. I sit in the clinic, every week, and as I see patients who come in, it is my hope that the stage 3 and stage 4 patients that I see in the clinic reduces over time, because, prevention has taken over, and we are looking at this across a period of time. I should see more, precancerous being diagnosed, and even less precancerous when vaccinations are working. So we are providing support from a government perspective on the required resources to make sure this happens, building capacity, providing the necessary infrastructure through our different levels of healthcare. We've had support working with partners, and I want to acknowledge and appreciate the role of partners and collaborations in this. We are a global family, and we learn and we draw different resources from one another. Now, technologies, innovations that are coming into place are really, helping, and we are adopting as, it gets approved. I know self-sampling has come a long way, and it's now acceptable as a way of collecting samples in our country. All that we need to do is how to do we scale it up so that it's utilized by majority of our patients. So thank you very much. I'm happy to continue engaging as my other colleagues contribute.
Yeah, thank you so much. So I will need to move to the next speaker and also save some time for the interaction later. So we have another online speaker, Dr. Garber Bello. Maybe if you can briefly share us about the Nigeria's efforts in terms of eliminating the cervical cancer. Yeah, really short, maybe in two minutes. And you have the floor.
So thank you very much for inviting me to share my own experience or our experience generally from Nigeria in terms of the cervical cancer, looking at the elimination agenda. Where are we as a country? So I want to briefly share my experience and also I can say the experience of Nigeria as a country. So where we are, maybe we have to start briefing, giving an update right from the journey so far that we had. So the quest to eliminate cervical cancer in Nigeria started since 2016 with an attempt to introduce vaccination into the system. However, that time we were faced with a lot of other challenges. One of the challenges was actually even the availability of the vaccine. And at that, they were kind of delayed because we are also among the countries that are benefiting from Gavi. So just to cut the long story short, in 2022, we were able to resubmit our application and we were able to get a kind of approval to introduce. Then in 2023, there was a release of an update on the availability of vaccine and also the SAGE recommendation of using single dose. So SAGE recommendation of using single dose was a game changer in terms of providing an opportunity for us to go into wide-scale introduction of the vaccine into the country, because we know globally that MAC, that's multi-age cohort approach, it has a better public health impact in terms of reaching the children and in terms of also having wider coverage. So the country really quickly switched from the use of double and dose, which was earlier approved by the Nigerian Immunization Technical Advisory Group, into the single dose, which was quickly approved and we submitted, and we also aligned with other partners. So on the 24th of October last year, the country successfully introduced a vaccine into cervical vaccine into the system with the strategy of MAC, that's multi-age cohort, as well as also routinizing the vaccine into the system. So those were actually the first component of the elimination strategy. If we look at the elimination strategy, actually talk about 90, 70, 90. So in terms of the first 90, the country was able to do well. Presently, our national coverage, based on where we are, based on the children that we were able to reach, we have 89%, because we did a phased introduction. We have 89% coverage of the vaccines. So we have the other component, which has to do with the screening, as well as also the treatment. So for the screening and treatment, what the country is currently doing around the 70 is actually to scale up the screening. What are we doing to scale up the screening as a country? Is actually to look at what we have as a kind of like DEX review of where we are as a country. So where we are currently, most of those screening are only taking place in the tertiary institution and the secondary institution. So, but over 80% of the facilities are in primary health centers. So we are trying to see how we can scale up the screening activities across the primary healthcare centers, working with all the other agencies of government as well as also the private sector. So presently as a country, we were able to have the country established a national task force on cervical cancer elimination, which was just recently launched or established by the country. And unfortunately, I'm also one of the members as a vaccine specialist on that group. So we had our inaugural meeting just last week. And part of what we were able to do now, we have a particular working group that we call prevention working group. So that one is dealing with vaccination and also screening. And the idea is actually to scale up the use of the modern system, that's the high performance test for screening. And at the same time, also, we are moving, just like my Kenyan brother, we are also moving towards self-screening because we realize that most of the women, they are really accepting that one. It's better for them to go and take the sample so that we can just screen. We are also leveraging on other structures that are currently available, like because of COVID-19, we have a lot of gene expert, we have a lot of those machines that we can use in the screening. So we are trying to leverage on the available resources to make sure that we scale up the screening intervention so that we move toward ensuring that we cover the component of the 70 and see where we can do. In terms of the 90 for the treatment, so I am working from the preventive component, but the current status of where we are, most of those interventions are in the tertiary institution. So with the current approach that we have around the sector-wide approach, we are trying to see how we can scale up the treatment centers so that we can have a wider coverage across the country. So generally, in a nutshell, those are some of the interventions that we do as a country. And we have a very good, solid policy that is supporting all those interventions. And we are aligning with the global community based on the WHO strategy of 70-90-70 to ensure that we target elimination of cervical cancer in Nigeria. Thank you very much. And I'm available also to provide other context and questions on the Nigerian situation. Thank you, and over.
Yeah, thank you. So now we have heard excellent programs on the ground, and also at the national level, there are political commitment initiatives to promote this goal, and also global level partnership consortium together to also address this elimination goal. So I will have like all round-up questions now to explore some challenges to move forward. So especially now, like we find ourselves at a time that is challenging to financing for health issues, with growing physical pressure at both national and global levels. How can we effectively like mobilize more funding and investment to support those innovations and the cervical cancer elimination efforts? So maybe for this question, Dr. Gupta and Dr. Huchko can share your insights from the global perspective. Our other speakers can share your thoughts from the domestic perspective.
So I think this is a very important issue, financing. So when we interact with the country organizations and also country leadership, I think one of the biggest challenges that countries are facing is really financing. So what are the opportunities for us there, understanding that countries are reeling under fiscal challenges, and particularly post-pandemic environment has just further exacerbated those challenges for governments, and they have to actually really very carefully consider trade-offs and then choose right among competing priorities. So one thing which I think is absolutely a low-hanging fruit is looking at those countries which are supported by Global Fund and PEPFAR, and zooming in on people living with HIV, and really identifying and establishing pathways for integrated services for this population. Because as I had earlier said, they are the ones who actually are at a disproportionate risk of getting cervical cancer and dying from it. So I think that's something that absolutely must happen. The challenge there is really that both PEPFAR and Global Fund have been very slow in transitioning to the newer methods of screening. So the guidance from both PEPFAR and Global Fund still provides only for VIA screening. And some of the analysis that we very quickly did on Global Fund grants was to really establish that less than 10% of countries actually asked for funding for VIA screening. So while there is a provision for VIA screening, its uptake has been abysmally low. So the point is, how do we leapfrog from VIA screening to HPV DNA testing and get PEPFAR and Global Fund behind that, because that's a population that absolutely must be prioritized and can be, because financing is there. The second, I think, issue is those countries which are self-financing economies. You know, they are not dependent on Gavi or sort of, Global Fund or PEPFAR, and clearly have a relatively better fiscal space. We also see that a lot of women in many of these economies are now earning. They have the willingness to invest in self-care and really protect their health, and therefore expanding delivery network through private sector partnership is absolutely something that should be considered. For example, one of the ideas that we are developing is to understand how the drugstores in many of these countries, and you have a drugstore in every neighborhood, right? And with these HPV DNA tests, what is the role that these drugstores can play so that women just walk across to the drugstore, access that HPV DNA screening test, return it there, and then, the drugstores have a tie-up with labs, private labs. And during COVID-19, we saw an exponential growth in lab infrastructure. And with all the digital tools that are now available in most of the countries, a woman gets her test result digitally. So I think it is quick, it is very easy in terms of access, and you are also making smart use of private sector and expanding delivery points for women.
Yeah, excellent point. Olatoun, you want to?
Let me also add that we also need to start looking at how to eliminate out-of-pocket spending for cervical cancer, whether prevention, primary, secondary, or even treatment. So countries need to start looking at how to embed cervical cancer primary vaccination and screening into the health insurance scheme of the countries, so that women don't need, the likelihood is that if a woman does not need to get money out of her pocket to get screened, or parents don't need to get money out of their pocket to have their girls vaccinated, the likelihood of increasing uptake is going to be higher. Another thing the countries can also look at is domestic resource mobilization. This has worked for other conditions like polio and also tuberculosis, especially at the state government level. So it's another area that can be explored, looking at how to advocate at the state government level on domestic resource mobilization. Yeah.
Thank you. Our online guests, do you want to comment on this question?
Yeah, I think that all of the points that you made were excellent. And I agree that, thinking about how we can leverage HIV resources, PEPFAR, the Global Fund are really important. But as the last panel mentioned, PEPFAR has done an incredible job improving the healthcare and research infrastructure for other health conditions. So I think thinking about how we can provide cervical cancer screening to the broader community and not just among women living with HIV or adolescents living with HIV will be really important. And I think some of the lessons learned about around negotiating drug prices can be applied to negotiating prices for testing and treatment supplies for cervical cancer prevention, thinking about what are the best practices in HPV testing and what is a cost, what's a price point that is going to be acceptable to the government to pay in a national health insurance plan and for public-private partnerships. I think there are so many opportunities with the sort of two most commercially viable HPV tests that can be used. One can be leveraged onto the most common HIV testing platform, or TB testing platform that is widely used among HIV clinics, and the other comes at a much lower price point and includes additional genotyping. So I think government involvement in negotiating lower costs for those tests is going to go a long way to increasing availability. And I agree with the continued challenge of only promoting VIA within the PEPFAR clinics. We've seen both low uptake and really continued challenges with the quality of care with VIA. And so women go away thinking they've been screened and they're good for another year or another 3 years, but in reality, the quality of the exam that they had was actually low.
Excellent, thank you. Yeah, so we hear about like mobilizing some of the HIV funding, partnership with private sector, and also try to get better priced products through negotiating the price, etc. I mean, all these like innovative financing mechanism might also need to be supported by the policy to back up these. So my next question is about like what kind of like policy levers or like tools we could deploy to help us achieve this goal, to put partners from different sectors together and also mobilize additional funding to support that.
Yeah, so I think, at this point, we do not have a very robust data to support an economic case for cervical cancer elimination. Because, when I was at Gavi and we used to advocate with the political heads of governments, we had better understanding of return on investment. So I remember, going and saying with a lot of confidence that $1 invested in vaccines actually fetches a return of $54 for them. So, that is an argument that really sort of swayed political will in favor of vaccines a great deal. But I think on cervical cancer elimination, that kind of value proposition is yet to be framed and articulated. We have some data saying, okay, $1 invested brings a sort of return of $26, but I do think that more work needs to be done. Because once the governments understand, the return on investment, then clearly there is a greater likelihood of building political support. For example, in Indonesia, with Minister Budi, who's their health minister, very proactive, I remember that was the starting point of a conversation, because Indonesia now has a publicly funded health insurance scheme. And I remember, visiting them a couple of years ago when I was with Gavi, and they were not thinking of introducing HPV vaccination at that point of time. And I think my argument was that they were having to pay for cervical treatment of cervical cancer. So prevention absolutely was better than, paying for treatment. And I think that actually resonated with the political leaders, the finance minister, and Indonesia moved forward with HPV vaccination. So I think that's just an example of how we have to bring better and better data to really convince the political leaders that they should be prioritizing a particular health program or intervention. The second thing I feel is that, for example, with Indonesia, we worked on this whole strategy for comprehensive cervical cancer elimination. And Indonesia became the first LMIC to actually stand up on the global forums and saying, okay, they would do it, right? With Australia, actually. So they are very ambitious. But the second then important thing is purse. So you may have a policy, you may have a strategy, but then where would the money come from? So in Indonesia, we haven't seen that happening yet. So that's a real challenge. But I agree with you that and that's the advocacy that we are doing with governments to say that if they have publicly funded insurance schemes, vaccination, screening and treatment absolutely must be included in that. Private insurance schemes coverage in most of LMICs is very thin at this point of time. So I think there is only very limited work that we can do. But in Malaysia, we saw that insurance companies are providing for cytology-based screening, but not HPV DNA screening. So there is some education that needs to happen. But the third important thing is really program. So once we have the financing, then I think program design and protocols really have to provide for integrated services. And that is easier said than done, because I think there has to be a big reset on the mental models that we have and the ways of working that we are so used to. And finally, it is the practices on the ground, because people are so used to working in silos. It is a question of turf territory. I've handled polio myself. And I can tell you one thing, that people who are working on polio do not want to talk about routine immunization at all, because they always feel that if by opening the doors for routine immunization, they're going to dilute focus on polio. So I think these are some of the things that need to change. And finally, partnerships. I think partners can do a tremendous job, by really leaning in on true integration of services, because that's smart spending. So a lot of waste that we today see in healthcare spending can actually be minimized if only people were to, act smarter and together. And for that, the donor incentives will have to change, because I do feel that it's incentives, by the donors that actually create perverse incentives against integration that we keep talking about, but don't really action.
Thank you. Thank you so much. I am super curious to hear from Dr. Malley and Dr. Garber-Bello, like from your national perspective, has any of these policy tools have been used? And if not, whether there's lack of evidence or other things that we can do together to also help you to push this policy agenda?
Well, thank you very much. This is a very exciting and catalyzing discussion. And I want to, again, acknowledge and agree, with all what my colleagues are discussing here. Now, from a government perspective, we do believe the game changer that will inform the successes of cancer prevention and control across all the malignancies will be driven by how we address cervical cancer prevention and treatment, because these are low-hanging fruits. Essentially, this would not be a very costly disease to treat. And if you look at the infrastructure that is required to address, primary and secondary and even tertiary prevention for cervical cancer, it can be replicated in all the other cancers. From a policy perspective in our country, this has informed, a whole paradigm shift in how, healthcare financing is being addressed in our country. As a government, we have political goodwill, and we are, from this week, began rolling out universal health coverage in our country. And we made it very intentional that part of this rollout, the cancer initiatives should be at the center of it. For a long time, a lot of initiatives have been on, HIV, and other NCDs, diabetes, hypertension, which are considered, to be easy to handle. But this time round, there's a serious policy shift, and this is informed by data, that if we invest in health promotion and prevention, we definitely will save a lot of resources. We've had a study looking at investment case for cervical cancer and breast cancer in our country. And it is very evident that if we are going to focus our resources more in, HPV vaccination and screening for early detection and treating those premalignant lesions, then we might not need to invest a lot in the expensive aspects of addressing, cervical cancer, which is treatment, where we got to invest into surgery, we got to invest into radiotherapy and systemic treatment. Right now, we are going towards precision oncology, and there is a huge challenge that, most of, low middle income countries and this setting might not have capacity for molecular diagnostics to that advanced stage. So then we do not want to get to that point where these patients presents with cancer. So in our community health programs, screening for cervical cancer using HPV is integrated, and health facilities have now they have the capacity to be contracted and be reimbursed from a social health insurer. When you talked about, unless countries invest taxpayers' resources for sustainability in our health programs, then we will still face challenges. We do recognize that, yes, Global Fund, PEPFAR, and Gavi, and other international funding opportunities have been there for a long time through the HIV journey. But the cancer affair is a bit unique because it is very cost intense, and we are aware that the donor funding is dwindling, in our countries. So we have to be very intentional from a policy perspective that, yes, we have to change how we deliver our healthcare services, and we have to embed the strategies, the initiatives to eliminate cervical cancer in our policies, in our government. We have a national cancer control strategy in our country that we are implementing to the latter, and it has 5 pillars, with pillar number 1 being prevention and early detection, what we are discussing here. And pillar number 2 on how to improve diagnostics. I know we have VIA, VILAE, we have traditionally considered pap smears, but it is very challenging. The opportunity for molecular diagnosis using HPV DNA screening, having very high sensitivity, it's what is standard of care, is what we are agitating, it's what we are adopting, it's what we wish should be a countrywide program, and financing is the center of all this. As a way of also improving and using catalytic resources, we are building a national cancer reference lab, because a lot of infrastructure in every vast geographical areas, we may not have resources to invest in a laboratory. So leveraging on HIV and TB, we are now improving capacity for our National Cancer Reference Lab, and these specimens will, there is a specimen navigation pathway that HIV and TB has created, and we are leveraging on that to make sure we centralize screening, using HPV and DNA, which is the standard of care. So I'm excited to report in this meeting that we have, a very intentional commitment of resources where it matters most. And we hope that as we deploy these strategies, we will begin the process of evaluation so that we can understand where are we over a period of time. And in our successive meetings, we should be able to track this and give additional information. Thank you.
Thank you. Thank you very much. Yeah, since we just have 5 minutes left, let me open the floor for the questions from the audience or comments on any of our panelists' experiences.
Can I? Okay.
Hi, good afternoon or good morning, everyone. A great presentation. Thank you. So I think there is a consensus that unlocking the private sector, engaging the private sector is key for scaling vaccination around the world. And one of the things I've heard is, engaging the community health workers, your trusted community health workers. But one thing that's missing is engaging pharmacists in vaccination efforts. And pharmacists, they've demonstrated during COVID that they are, number one, they're trusted professionals, but they're well positioned to address crises and also able to scale at large when it comes to vaccination. And I'm with PSI, Population Services International, and in collaboration with the funding from Takeda, we're going to be bringing pharmacy-based immunization to 3 countries in Africa. We're going to, Dr. Mali, we're coming to Kenya. Dr. Bello, we're coming to Nigeria, and we're also going to Ethiopia. And I think this is an area that everyone needs to be looking at. What else can pharmacists do? How can they help with screening in addition to vaccination as well? Thank you.
Thank you. Anyone want to reflect on that?
I would, let me comment. So that this is an excellent point. In fact, this is what I was alluding to when I was speaking about drugstores, because drugstores in most countries can be run only by trained pharmacists. So I think pharmacists, we have big numbers, in most countries, and actually their potential has not been tapped into. And if we really talk about Africa, Africa has the largest shortage of health workforce. And while other regions in the world are sort of, taking steps to add surge capacity. For Africa, WHO projections show that this crisis will continue to loom large. So I think we have to, so there is a lot of talk about paid community health workers, but realistically, I think it's going to be very hard to achieve that goal. So I agree with you that in parallel, we have to absolutely explore other resources that are available to us but haven't been harnessed to their full potential. So pharmacists absolutely are among them. Just one note of caution, because we are also working on this idea. So and that's just a personal view that, for screening, it is much easier. But for vaccination, we have to be very careful, particularly a vaccine like HPV, where there is already a lot of mistrust and misinformation, and adverse effects, following immunization have to be monitored very carefully. So there has to be very rigorous quality assurance around selection of these drugstores run by pharmacists, so that we don't absolutely create a situation where the declining community trust is further eroded.
Yeah, great. Actually, we will have next session on trust, so we can definitely have a deep dive.
Okay, do remind that the first day I told you about the urgent need to go on poverty, not only on healthcare, but the root problem is the poverty of people. I'm from Mexico and indigenous communities, and I think poverty, the access to many resources, human rights, it's one of the worst things that happens to a human being. I want to share something with you that, for example, in the state of Mexico, in municipalities that we are working since many years, 15 years, we are helping people to have food security programs, access to water, and all the food they produce, they eat, and they sell, that food is organic, without hormonas. I don't say how to say hormonas, without that. And now we are with a new municipality. And in that new municipality, we are detecting cancer. We are starting on the poultry and all that without the hormonas and the organic food, organic vegetables, and things goes perfect. I work in alliance with a specialist. I only gather the people, our team, and specialist organizations do that and take care if they detect some problem. But I want to share this because it's important, because we are always trying on the last mile when we have the disease, when they have the problem. But making this investigation probably with Duke, we can go further and further to see if the way the nutrition, if that is solved, the problems of cancer would go down, because this for me is something that I need to share, because it's strange. It's strange that the new municipality, even I have a girl of 4 years old with cancer here, a girl. And for example, the reproductive age of indigenous woman started after time ago was 12 years, more or less, and now it's 8 years, 9 years, and that is terrible, because and I think the problem is the same, to take care of integral development.
Yeah, thank you so much. I'd love to continue this conversation, but we have to end this session. Maybe we can meet during the network break. But thank you, our excellent panelists, for sharing your insights. And we have known about thousands of diseases, but cervical cancer is indeed one of the very few diseases that we can possibly eliminate that with this existing tool. So really look forward to collaborate with partners together and to address this health issue. So thank you very much.